you, Jake. Right, so welcome to today's meeting. This is the Children and Adults Health and Wellbeing Policy Development and Scrutiny Panel. For anybody who has been watching, I apologise, we've had some technical difficulties, but we have started the meeting and we have gone through a number of the items, and we are now on item 5, which is urgent business agreed by the Chair, and there is none. So we now move on to the public and councillor statements and questions, and I would like to welcome Nicola James and Baz Harding-Clark. I assume because you're listed in this manner, Nicola, you would be speaking first. So you have 3 minutes, and I very much look forward to what you have to say.
Hello, thank you for permitting me to make a submission at short notice. My name's Nicola James, and I was elected as Public Governor for Bath at the RUH in 2002 and served until July 2024. I attended the meetings, read every paper, and what I'm about to put to this panel's record should concern every councillor in this room. In September 2023, the RUH Public Board paper stated explicitly that the Trust strategy was to grow the staff bank. Direct quote, "We are looking to support managers to develop exit plans for high-cost agency workers by recruiting to vacancies, moving agency workers onto our bank." I heard that case made repeatedly. Experienced workers who knew the wards and the patients worth protecting, we were told. By March 2026, the Trust had completely reversed that strategy, abolishing the staff bank entirely and handing it to a private equity company. No public explanation, no long-term cost modelling, no transparency about what changed. The projected saving of 3.3 to 5.4 million comes entirely from cutting employer pension contributions from 23.7% to 6%. That's not an efficiency saving, it's a cost deliberately shifted onto the workers to plug a deficit. The Trust's own consultation document named Pulsar Caesium as preferred bidder before the union consultation period had even closed on the 4th of March 2026. This panel should ask the Trust to explain how a preferred bidder was identified before consultation concluded and what weight, if any, was given to union feedback. This panel has a statutory right under the Local Government and Public Involvement Health Act 2007 to be consulted on substantial variations in local NHS services before decisions are made. Removing hundreds of workers from NHS employment across 3 trusts, formally opposed by recognised trade unions, is exactly such a variation. My understanding is that this panel was not consulted, its statutory rights were entirely bypassed. The executives making this decision will not be accountable for its consequences. When the Acacium contract comes up for renewal, when there's no in-house bank to fall back on and costs escalate, these executives will have moved on. The workers who lost their pension contributions will still be living with the consequences. The taxpayers who fund this will be paying the price, as will the patients. This is not responsible financial stewardship. This is deficit management by sleight of hand. And this panel has both the right and the duty to call it out. I'm asking this panel to call an emergency session before August, requiring BSW Trust executives to attend and answer for this decision before it becomes irreversible, to write formally to the Secretary of State and to formally note that its statutory consultation rights were not observed. Thank you.
Thank you. Would you like us to hear your statement, Baz, before we ask questions?
Hello, so my name is Baz Harding-Clark and I am the Branch Secretary of Unison at Bath Health Branch. I also serve as the Chair of Staff Side at the RUH. I am also directly affected by this decision in my clinical role. I've worked at the RUH for 20 years. I represent the workers directly impacted, and I've also formally written to the Secretary of State, West Streeting, about it. I'm here because my members have been failed by every formal channel available to them so far. Bank workers are not being transferred. Their NHS bank employment will cease on the 1st of August without choice. If they want to continue working bank shifts at the same hospitals, the only option will be to re-register with a private company called Pulse, who are part of the ACM group, a private equity-backed organisation. There is no continuity of service, no NHS terms and conditions, and from that point forward, no ability to continue accruing their NHS pensions. For a healthcare assistant working a bank shift for another 10 years, the difference between a 23.7% NHS employer pension contribution and around 6% in the private sector represents tens of thousands of pounds in lost retirement income. The Trust's own Equality Impact Assessment shows that the RUH 56% of bank workers are from an ethnic minority background compared to 27% of substantive staff. Between 64% and 87% of bank workers are women, depending on the site. The proposed mitigation for this disproportionate impact is quoted verbatim: encourage bank workers to take up substantive employment. This is not mitigation. That is telling predominantly ethnic minority, predominantly female workers to reorganise their lives to suit the Trust's staffing model. The consultation process initially excluded bank workers entirely. Only after unison challenge were they invited into informal sessions, not a consultation. They were presented with a decision that had already been made. Both Unison and all staff side formally opposed this in writing. We were heard once and then overridden. I have written formally to the Secretary of State describing that this is a privatisation by stealth. No response has been received as yet. This panel should add its voice to that letter without delay. We have seen similar patterns before at Great Western Hospital, one of the trusts that are involved in this decision. Outsourced facilities services have previously led to disputes over pay and conditions, including industrial action involving workers employed by Serco. These situations highlight the risk when staff are moved out of NHS employment, particularly around pay parity, accountability and terms and conditions. That is what else outsourcing looks like in practice, and this is what the future for bank workers face. Thank you.
Thank you very much. I'm just going to ask for clarification on 2 points before I ask the panel for if they have any questions, if you're happy to take questions. The first one was, I didn't hear what the proportion of bank staff were women. I know you quoted a figure, but I didn't write it down.
Between 64 and 87% of bank workers are women, depending on what site, so that's across the 3 hospitals.
64 to 84?
64 to 87.
87, thank you. And then my second question was, you said you'd written to Wes Streeting, Secretary of State. Was that as a formal call-in, or was that just raising your concerns?
So mainly raising concerns around privatisation within the NHS and the commitment that Wes Streeting gave to us.
So just to confirm, you've not actually asked for a formal, you've not formally asked for a call-in of this decision?
No.
Okay, thank you. Right, panel, who would like to speak first? Joanna?
I know this sounds like a really silly question, but to the average person, what is a bank staff and what do they do?
Okay, so sorry, I should have explained that to you. So our bank staff are temporary staff and they fill the back gaps. So when we're short on nurses, let's say in A&E, it will go out to our bank staff first of all, before it goes to any agency. Some of our bank workers only do bank work. It's not as if myself, I'm a substantive member within the IUH, but I also do bank work alongside for extras. But some of our bank workers are solely dependent on that role itself.
So by taking this away, what will that do?
So taking the bank away will put the trust at risk of not having staff to fall back on as short gaps, or to fill in where annual leave or vacancies that have not been filled, those type of thing. So it puts a risk. If I use A&E, because A&E is kind of a topical point for most things when we come to staffing, if 6 staff go sick in A&E, we have no fallback.
And what would that mean for patients?
So that would put patient care at risk.
Thank you. Leslie and then Paul.
Yes, thank you for your statements. Can I ask you first, Nicola, what sort of public interest is there in this? Because clearly there's going to be an impact of some sorts. I did get sent by a union member the report with the equality impact assessment in it. I'll say no more about that for now. But I'm not sure how much has got out there. Is there public interest in this?
About it almost a week ago on predominantly Twitter with a link to a longer piece which shared some of the facts.
Would you mind speaking more directly into the microphone?
Yes, thank you. I posted about a week ago on Twitter with a link to a longer piece on Substack which covered a lot of the information that Baz and I have shared. That's had a huge amount of shares on Twitter. I think the last time I looked at it, you know, sort of in the tens of thousands now, and it's been shared on other platforms as well. And we've had a lot of feedback, and people have contacted me. Protect Our NHS hadn't been aware of it until they saw that, and lots of private messages and comments in the thread, and different unions that didn't seem to be, you know, sort of aware of it. So yes, quite, yeah, a surprising reaction and lack of awareness.
Just to add, this hasn't gone public yet. It's only been handed to the staff or bank workers through sessions. I've been told by IUH management that they will be going public with this, but they haven't as yet. So it's only internal comms that have gone through.
Thank you. For yourself then, Baz, I mean, it's interesting you saying it hasn't gone public. We haven't heard about it either. And I understand there was a report back in December last year, but we haven't had notice of it. We seem to have a bit of a rerun of how the HCRG contract was awarded. We found out about it after the fact, and had no scrutiny of that decision whatsoever. But can I ask you, you've talked about the staff that will be affected. Clearly, there's around 75% of staff in the NHS are women anyway. So do you have any information about how that is going to affect people in the long term? People are not paying pensions. Where are they going to be in the future with regards to how they're going to manage once they retire?
Yeah, thank you. Good question. So this is one thing that we've been raising with the trust's management systems, and we don't actually know. We've been told that there is no pension. Once they go over to Pulse, they will cease their NHS pension, and they will then go on to a 6% pension scheme, which then will, in future, especially for our long-serving staff that have worked on our temporary staffing, and some of my colleagues have worked there for 30 years on temporary staffing, they will now lose their whole NHS pension. It will now just become to an end. No more contributions.
Can I just come back on one? I mean, when staff are moved over, will they still be recognised, will the organisation still recognise them as the unions, and will they be recognised in any other Agenda for Change agreements? Because Agenda for Change was brought in to make sure there was equal pay, and if those things go, I'm not too sure what's going to happen to equal pay, which nobody seems to have managed to do anyway so far, but that's not the point, is it? We're supposed to be, under the law, moving towards equal pay.
Another question that we've put to them, and their answer was they will have local rate cards. Now, we understand that local rate cards mean nothing when it comes to private entities. They will fall out of Agenda for Change. They will not have any NHS protections at all, terms and conditions, and that includes the Agenda for Change rates.
Lucy, it might be useful for you to come in now. I'd particularly be interested in that point that was just being made around protection of pensions, because I understood from, 2P that those pension, that would be protected, but you might not know the answer to all of that, obviously.
Thank you, Chair, and I'd like to thank Nicola and Baz for your statements today. I received a briefing from the IOH this morning on this matter. In our role as Strategic Commissioners for BSW Somerset and Dorset ICB, we will now be working with BSW Hospitals Group to understand the plan and the implications, and my commitment would be that we would bring something back to this committee once we've done that work. I'm unable to comment on the detail, as this is not a decision made by Strategic Commissioners. This is a decision made by BSW Hospitals Group.
However, I think the point that was well made is around that substantial variations, and therefore it does become a matter for us as a panel to be aware of and to comment accordingly. So, but I thank you for your promise to bring something back to this panel. Paul, and then... no, it's Dave Harding first, and then not Liz Hardman.
Yes, can I just check one thing before I ask my question? As this has not officially gone public by the IOH, it is now public because this is a public meeting. Is there any problem with that process that we've now made something public that wasn't public?
It's a very good question, Paul, and Lucy, and maybe Darryl might want to respond.
Thank you. So I have made BSW Hospital Group aware that this has been discussed today, so they know it's been discussed. I will take that question back around if there is any process implications, but they are aware that the statements are being read today.
Right, thank you. My question is, does this private equity firm have any other contracts with the IOH at the moment, and how is it chosen? Because as a matter of principle, I think outsourcing is never a good idea. It's only got one objective, and that is cutting costs and reducing benefits to the people that are outsourced. So as a matter of principle, I think outsourcing is a thoroughly bad solution to whatever the problems are that they've got at the RUH. But is this private equity firm, who is it? Can it be named? And what is their track record? And do they have any other contracts with the RUH?
And it might also be worth just considering where we are in that. I think the contract, did you say, had been awarded already? So it's now the negotiations with individual bank staff. So Lucy, did you want to respond to that?
I don't have that information. As I've said before, it's not a decision that's been made by BSW ICB. I'm happy to take the questions back to BSW Hospitals Group.
Thank you. Baz, you wanted to just come in?
Yeah, just in response to Paul, there's no other contracts held at the IOH by Pulse, which is also known as bank partners. And also, just going back to the publicity bit, so they have had open sessions with staff, so I think they've had 7 or 8 open sessions, so technically it is public information, but what I'm saying is they've not gone public on a national scale, if that makes sense to say this is what's happened. They've just spoke directly with the bank workers.
And you said the company is called Pulse, and they're also known as
they're known as bank partners.
Bank partners.
Yeah, and as far as I'm aware, the only contract within the NHS is with Barts Health up in London. They've got a similar model up there, which they've been doing for 10 years.
Thank you, Baz. Right, let me go to my list. David, and then, Michael, and then not Liz. Michael?
It was just, in terms of the bank, is it all the different roles within the IUH that are covered within that? And my daughter is a nurse, and I'm well aware of how important bank staff are to the ongoing running of any hospital, and how staff that they've been trained and worked in the NHS for many years then go on to bank because it fits other aspects of their life-work balance. And to lose all that pension and all that build-up is phenomenally. I've been terrified to know, because I know what an impact both people work in often challenging conditions within the NHS, and what other benefits they might have if at the end of their career they have a decent pension to live off, and to lose all that because of this, a decision like this, I think is absolutely appalling. So,
yeah, so this will cover all non-clinical and clinical staff within the IUH, excluding medics, I believe. The medical team use a different system, but I need to get clarity on that because it was a question that was asked today, and I'm not 100% sure if it does include our medical teams, because booking there, so doctors book through the staffing solutions, and that's where our staff are. So the substantive staff within staffing solutions, where our temporary staffing is based, will be 2P'd across as well, so we won't have any internal bank structure.
Thank you. Maybe that's a question, Lucy, that you can pick up as well. I just want to make a comment, actually. I just think it's just shocking that you didn't hear anything about this until this morning. So I will just leave that there before I say anything further. Eleanor and then Kevin.
On the wrong side. Sorry about that. I was on the wrong side, and I hope we're not on the wrong side, thinking about the welfare and the amount we owe to the IUH staff for their dedication. And it seems a pity we're now talking about cuts and financial reduction and so on, when if staff weren't prepared to work long shifts, we'd be pretty well sunk. Now, the person I saw on Friday is just about to go off on maternity leave. Would I be right in thinking that were she a bank staff, she would have absolutely no internal maternity rights or any pay or anything apart from what the state provides, and that if she decides she wants to come back through the bank system, she'll have no choice but to go with this private company who may not look after her in the same way that the internal bank structure would.
Baz, would you like to speak as well as indicate?
Yeah, of course, yeah, that's correct. If any bank staff, if any person goes on maternity now and they want to return on bank, it will be through that private system. It won't be anything to do with the NHS, and they will lose their rights.
Okay. You
Would
can,
I be
but
right
be
in
careful
thinking
though.
that,
You don't want to identify any individual.
Sorry?
Just be careful you don't try.
Exactly. That's why I didn't say which clinic it was. No. Would I be right in thinking that many staff opt to go into the bank system because it gives them greater flexibility on the choice of what hours they are available to work?
Baz?
Yeah, that's correct. So we have a huge proportion of our staff, again, hence why there's up to 87% of women that are on our bank for that reason, for flexibility around childcare and also for people that are carers as well for disabilities and within their families. And
Thank you, Baz. Kevin and then Leslie, and then.
Thank you, Chair. Just would like to pull out 2 points really from the things you've been saying. The first one is the effect on the level of service around the loss of experienced people that are, if you like, attached to that particular site and hospital. And the other point was around what reasons have you heard that the hospitals are doing this? What have they given to you as why this is a good thing? And if you can sort of pull out a bit more around the sort of loss of service that you foresee if this change goes on.
yeah, of course, the easiest part I can answer is what the trusts have told us why they're doing this. They've told us they don't have the infrastructure to cover all 3 sites. which is ironic considering they've got their own bank setups as it is at the moment, so there's no real change that we can see. From a union perspective, we've looked at the structures that they use within those trusts, and they use a system called Allocate. If they were to just pay a little bit more for that system, they could get Allocate Cloud, which brings all three trusts together. So we don't believe it's a valid reason that they've given us. And given the fact in the consultation paper they have quoted that there will be a saving of up to 5.4 million, we believe it's a complete financial reason. Oh, sorry, I just cut out. And then the second part sorry, what was the question again? Sorry.
The loss of service that you would anticipate with this change.
Speaking to our members, they've already told us that they won't be signing up to the private company and that they will pull out altogether, so we could lose valuable skill set, knowledge and years of experience due to this decision. And that, again, will not only impact patient safety, but also staff safety as well. Having people that have not worked within those hospitals with that level of experience, in especially specialist areas, would put other staff at risk as well.
Can I just add to that? The hospital have indicated a financial saving, but that's only modelled on the first year. It's a little bit like PFI in terms of they're kicking the can down the road. They know that the costs are going to increase, but they won't be there to account for that. They're just plugging the deficit in year one and maybe year two. But beyond that, we know what's going to happen.
Thank you very much. Now, I've got three more speakers, and then I've got a course of action that I was going to suggest. So if I take Leslie, then Joanna, and then David, and then I'm going to draw a line there. Okay? So Leslie, and then Joanna.
So I understood that within the NHS, if a service was going to be outsourced, that the unions had to agree. And you're telling us that the unions haven't agreed. So, so what happens now? And I think also for Lucy, will you ask the question, because if you're going to outsource, it has to benefit, surely, the service users, patients in this case, and presumably how that's going to impact on staff. So will you be asking that question? And I'm a bit worried about what you've said, Nick, just now about the savings are modelled on a year, which seems a little short-sighted. Do you have any more figures around this at all that might help us here? And the other thing for me is, how do you know how this outsourced service is going to be monitored? Because we're already starting to see issues coming up with another outsourced service. And I think it seems to me, after having gone through the process that we weren't involved with the last privatisation, outsourcing of community services, that it looks like Bath and North East Somerset is being used as a soft touch. Lots of our public money, whether it's through the council or through the health service, is going into the private sector. And we're not going to see that coming back for our residents in any kind of way, because they're not paying the tax. On a private equity company, they're not obliged to declare what they're paying. I've got no idea what they're paying. But if money's not coming back into the system, and let's face it, the NHS contributes massive amounts into the system through taxes. So if we then move them into an organisation that's, one, not going to pay tax, and they're not going to be getting a pension, what's the long-term impact of that going to be? It's terrifying, really.
Baz or Nicola, I don't know if you want to respond.
I can answer from the unison side, the union point of view. So when we put our opposition in, it was listened to and then overridden, and they went ahead. And there was no more talks from that point. It was then we were then just informed. I'm currently in talks with my regional teams at the moment as to what move we make next from a unison point of view. But just for clarity, there are 13 unions registered with the RUH, and all of them have opposed this.
My understanding is that there's absolutely no modelling of what happens when the contract comes up for renewal. So there's no assessment of costs if infill rates drop and the trust returns to agency staff. No analysis of the risk over the contract lifetime. So the saving is stated, but the risks are unexamined and undocumented.
Thank you. Lucy.
Thank you, Chair. I just wanted to come back on the elected member's question around what the ICB will be asking, and just to assure her I will be asking that question as part of the work I've previously described.
Thank you, and I'm sure you'll be picking up on all the points that have been raised subsequently as well. So, on my list, as I said, I've got Joanna and then David, and then, as I said, I'm going to put a proposal to you. David, sorry, Joanna and then David.
Thank you. I just wonder who are the people who have made this decision at the NHS Trust? Do we actually have their names? I mean, they must be senior managers.
Yeah, so it's come from the board of directors. It was one person in particular, I believe, and then that's now been agreed at board level, so all of them are in agreement. As far as we're aware, we've been told they're all in agreement with this.
And then my question would be that I don't think it's enough that we have Lucy Baker making a comment or asking questions about this, that actually the BSW Hospital Group senior management should be in this room explaining to us what's going on, how they've made that decision, who's made that decision, the finances based on that decision, because it does critically impact patient health. And as we've known, that is a statutory duty for them to make sure that that is scrutinised by this group of people before they proceed. They have not done that. So I don't know about the law, but have they actually broken the law by doing that? Or are they in contempt of it, and should we act on that?
No, so I'm just having confirmation that you're broadly right, and actually this does look like a substantial variation, and therefore they should speak to us, and they do have a duty to speak to us. And Lucy, I don't think you wanted to respond, but absolutely, you know, part of what I was going to propose is that the BSW Hospital Trust do come and speak to us.
Thank you, Chair. Thank you, Councillor Wright. So the action I've described for the ICB is around our role as Strategic Commissioner. That is not replacing any direct conversation that members may wish to have with BSW Hospital Group. I just wanted to clarify that.
David.
Thank you, Chair. Councillor Manson and Councillor Wright have actually raised the issues I wanted to raise, and I support what they've said.
Okay, so the course of action that I was going to propose is that actually we ask for Lucy to do what she has proposed, and also that we ask for the Hospital Trust to respond to us as well. I'm going to ask for this to be in writing within the next 5 days. I suspect we will want to have an interim meeting to consider these responses, because what I think we would want to do is we would want to raise our concerns similarly to the way that Baz and Nicola have already done, around the probability that this decision will affect the provision of services to our residents in Bath and North East Somerset. However, before we can do that, we do have to have asked the other side to have responded. So that's what I'm proposing that we do. So we have, you know, the questions that have been asked replied to in as shortest time frame as possible, and then we have another meeting to determine whether or not that adequately answers our concerns, or whether or not we actually want to take this to the Secretary of State. Does that seem something that everyone can agree with at this moment? Yeah, I think we are all, though, very concerned that the ICB was not made aware of this course of action until this morning, and it feels very much like that Lucy was only alerted because that you were coming to speak, and I think there is something about the process that needs to be re-examined, and that could certainly form part of our questions to the Secretary of State as well, particularly as ICBs are changing in shape and actually by being bigger, that immediacy, you know, in terms of how we react as local representatives, I think is also impacted. So, okay, so is that Joanna?
Are you, it's a bit woolly at the moment. I'm just trying to work out, are you confirming that this scrutiny panel will be writing to the Secretary of State as well? Because that seems to be an urgent matter on this.
We'll write to Secretary of State on the back of that response, because when you hear one side of an argument, you do have to hear the other side before you can then take a course of action. But I'm not pushing it into long grass. That's why I'm saying I want those responses in the next 5 days, 5 working days. So then we will have and we may be able to do it through email, but I suspect we will want to actually meet to just confirm that course of action.
Okay. As long as there's a process and we aren't leaving it like over the next month, we will have a process. We might have written also to the Secretary of State.
Absolutely, yes.
Thank you.
Absolutely. Okay. Right. So thank you very much, Baz and Nicola, for coming and speaking to us. And I think I speak for us all when I say we are very disappointed that, you know, with what you have told us. Okay. You may stay for the rest of the meeting if you wish to, but you can also free to go too. So thank you. Right, moving on to the next item, which is the Cabinet Member update. And thank you once again for circulating this before our meeting. Is there anything else you wanted to add to your report?
No, I mean, just to summarise really, the dementia strategy, there's an update on that. That's a process that we are in the midst of, and we're using a co-production approach to produce that, and we will provide further updates as we progress. There's a couple of updates on the sensory impairment support service and the advocacy services, which are both new contracts. And it's the how they are bedding in, really. Also an update on the recommissioning of the learning disability care home and home care contracts, and that's a process that it has just started. So again, we will be keeping this group updated as we move through that. The learning disability provider services that we provide, some of the services that we took back in-house, they haven't been reviewed for a long time, and we are reviewing them to ensure that they are fit for purpose for meeting the current needs of the people who use those services. So that's a process that we're engaged in, and again we'll be working closely with staff and with the people who use the services on that. That's really just giving you the heads up that that's work, and again there will be further updates on where that's taking us. There's very good news about the Coombe CQC inspection. We were absolutely delighted to get a rating of good on that, and it was a really positive report. And then there's a few public health updates which relate to, firstly, the Drug and Alcohol Conference that we held in February. That was the first one that was held in Baines, and we're hoping it's going to be an annual event. It was very well attended. I attended, and it was really interesting. We had some excellent speakers. Then there's a response. I think Liz, it's unfortunate Liz isn't here today because she asked for further information on the food benchmarking survey and the food strategy. Just to say, Paul is here. Paul is now the Acting Director of Public Health. We were sad to see Becky go, but I'm sure the department's in very good hands with Paul taking the leadership. And the one thing I missed was the Active Way, which is the social prescribing project that we had government funding for. It's been really successful, and there was an evaluation by University of the West of England, and there's a link to a blog on that. So that's a sort of quick canter through, and I'm happy to take questions, which between us hopefully we'll be able to answer.
Thank you very much, Alison, and welcome Paul Scott, who is, as you say, the Interim Director of Public Health, and I'm sure will be very able to answer any questions we have on public health matters. So, panel, any questions for the Cabinet member? Okay, you're definitely first, Kevin.
Oh, thank you.
Alison, do you want to turn your microphone on?
Congratulations on the report for the CQC inspection. Can I just clarify then, has that now meant that all the care homes are good now?
All the extra care, 5 extra care are all good. Coomley is good, and Cleve Court is 1 mark off good. I spent the day with them on Friday, and they are really, and speaking to the residents as well, they're really, really wanting CQC to come back now. They're ready. So we expect, but I don't expect them back for at least 2 years because they're not worried about Cleve Court. So unfortunately, we'll have to wait. But 1 mark off has been really difficult for the staff and the residents there.
With the resources and, I mean, obviously a lot of work's gone into bringing where you want to be now. Do you have now the resources to sustain that and the people in place to sustain that after all the work that's carried on? Because sometimes there's an awful lot of input or extra resources when times are difficult or challenging, and then suddenly you find yourself, well, okay, we're now on our own. Will there be...
When the care homes and extra care came back to us, we were 3.1 million over in agency. We were spending that amount of money on agency that we didn't have. That was 2021. We've got a balanced budget now for the care homes and extra care. We've got all permanent staff in the management. We have very few vacancies, and we've got a big bank that we're utilising. So that does make us sustainable as we go into the future.
Thank you. Any other questions for the Cabinet member? Leslie first.
Yes, thank you for the report, and many congratulations to everybody that's been involved in achieving the good rating from CQC. We know these are not easy to get, and I think it's important that we note that that's happened. But my question is around how is that good rating going to be sustained within our area? The other question I wanted to ask, which is still outside the report, is on school streets. So what's happening with that? Because I'm told it's supposed to be happening and it's not. And the other question I wanted to ask is around the previous discussion we were having on the outsourcing of the temporary staffing bank at the RUH. Have questions been raised by the Cabinet member on that whole contract, etc., at the council? I think it's the Council of Governing Board, I'm not quite sure what it's called. But I understand that the Cabinet member sits on that, so I just wonder what questions have been asked.
Right, well, in relation to sustaining the good rating, I think Suzanne, in her answer, talked about the building blocks that need to be in place in order to sustain a good rating in services, and I think that is about having substantive staff, having consistent staff, having good systems in place, and at the moment all those things are in place and we are fully intended maintaining that. I mean, we can't guarantee that we will do going forward, but it's certainly our intention to do that. And as I said, I think the foundations are very much in place to maintain it. So that's that one. In relation to school streets, that's not really this panel, but my understanding is that they are coming into place.
Yes, I'll pick that up actually, because I believe it's looked at by the Climate Emergency Scrutiny Panel, and Lucy Hodge has the cabinet lead on that. And there's a dedicated website, I'm told too. So, which Kerry will send to you, Leslie. Okay.
Okay, and in relation to the changes at the RUH to the bank, I was not aware of that either, so I have not asked any questions.
Thank you. I have... sorry, I nodded to somebody who put their hand up. Kevin, okay, and then Joanna.
Thank you. This is more a public health question, or a couple of questions. I did mention earlier on, which Lucy may have mentioned, that she was going to talk through as well. But anyway, what came up on the Radio 4 this morning fitted in with what I was going to ask anyway around your supervised brushing programme in schools. And on the Radio 4 this morning, as Chris pointed out, there was a great deal of concern mentioned about the cut in health visitors, particularly in England, and that sort of raised the issue around, so what's it like in Bath and North East Somerset, and do you think we have enough health visitors, and how many health visitors are there per whatever you do per? And it tied in with my question around supervised brushing, because as a previous primary head teacher and getting to the point where we had further and further cuts in all public systems, we got to a state where we just couldn't take on any more additional duties as opposed to just our core purpose of education. And yet again, we find we have supervised brushing, which you would think actually by the time the child has reached 5 and started school, they would be able to brush their teeth, or would be in a routine of doing so. So therefore, it seems a bit, yes, of course, schools will do work around personal social health education, about personal hygiene and all those sorts of things, but to supervise brushing of teeth sounds a bit difficult, you know, and a bit silly. It should have already happened a long time ago. So the question was, should this be a health visitor role, not a school role, please? And the other couple of questions I had was around the public health report. The food strategy was mentioned, and I suppose I'm just trying to understand where this is sort of directed at. So what are the key needs and gaps that it's addressing, and who it's addressing, and how that fits in maybe with the Fair Food Alliance work and things which we haven't heard a little bit about for a while. And finally, and again, these may have been big things, but I haven't quite got hold of them yet. There is the whole systems approach to better health and the disadvantage gap. And one of those things was a cross-council action plan, which I haven't actually yet seen, and I'm not sure whether that I have no idea which actions are being taken and how. But then there was 2 particular projects that seemed to be happening, one around a community and one around an education setting. And again, haven't heard anything else about those. Particularly interested in education one, of course, from my stance. But what's happening and what's it done so far and what's it aiming to do next? So nothing really much.
I'm sorry, you missed the bit where we were making sure that all of our microphones worked. Otherwise, you look like you're Alison.
How do I sign in?
This side.
Jake's on the case.
Sign something else. Okay, so it's not recognised, unfortunately.
Trying to get on this one.
Or on that one.
I'll be better putting this one.
Yeah. There we go. All right, thank you very much. Hi, so yeah, I'm Paul Scott, Interim Director of Public Health, and thank you very much for your questions. I'll try and go through them one by one, but please, if I've missed something or not quite answered the question, just say. So the first one around health visitors, we have had consistent good health visiting services in place and recently re-procured at the start of the 25-26 year. I can't give you a figure on whether we have more health visitors per head compared to comparable areas, but I could come back with that. There's something about making sure, in relation to what you were talking about, and oral health and dental health of children, of making sure we've got that focus on our more deprived areas in particular, and perhaps on areas where we have worse oral health, because we know there's a strong association for children who are in more deprived communities likely to have missing and filled teeth by the time they start school. So I think that's where my main priority would be, that we're focusing our efforts in the right places. There's also, with the Best Start in Life programme, a renewed emphasis on trying to have more innovative ways of working with young families, not, for example, working with schools, but also working in other community settings and just being innovative beyond perhaps traditional home visits and things like that. But I can find out more about the actual figures if you like, and I heard the same thing on the Today programme this morning. In terms of working in schools or not, I think there's a role there, but completely take on board just how busy schools are. And I guess it's, again, probably working with those communities where some children may still benefit from those kind of schemes. Some people have a negative view of them, but they can still have real benefit for people. But it's still a health visitor role. There's still other roles in the community as well, not the responsibility of schools, as it were, purely. But I think my colleagues who are close to that would probably still see a really important role of using different venues and settings where children will still learn real important skills. In terms of the food strategy and how it fits with the Fair Food Alliance, I'm not actually entirely sure of the governance, but there is a broad range of people involved in it. In our recent survey return that Councillor Bourne mentioned in her update, we had some areas of strength, particularly around things like sustainability and reusing or reducing and recycling of food waste. They were areas of strength, and around sustainability and access and community work. But some of the governance was at a slightly earlier foundational stage, so there might be something about checking. I know it is a multi-organisational and disciplinary approach to it, but I can check in on how it links to the Fair Food Alliance and get back to you, if that's helpful. And on the last one, on Be Well Baines, you're right, it does have a number of strands and has been perhaps overly ambitiously trying to move them all forward at the same time, which then makes it quite hard to come back with more visible progress. Some of the work has moved forward faster, and it would be probably really helpful to give an update to the panel at some point on the progress or next steps on Be Well Baines, if that's helpful, if we get the right timing for that. And some of the work, as I say, has made more progress than others, so it might be useful to have an update on that at some point.
Thank you. And actually, for anybody who was a bit confused, the Member for Adult Social Care covers public health, which is the whole life of a person. So public health is across children as well as adults. So, and thank you for your very clear response. But yes, I think we might want to hear a little bit more about that in due course. On my list, I have Joanna.
Thank you. Thank you for the report. Just as an aside, two things. One, the school streets. As chair of chairs, I'm still confused by this. I mean, it's a massive public health issue, and I don't understand why there isn't an ability for this issue to be across two scrutiny panels, and since it is a public health issue, why this group is not involved in that process in any shape or form.
Okay, we're having a meeting next week, and I think we have spoken about this before, because at one point we were going to have a member of this panel sitting on that panel. So I will bring that to the attention of that particular chair. As I said, it's the climate emergency panel, and I know that you're particularly interested, and if that's okay with you, I will put your name forward. Thank you.
My second question is to follow up of the play motion that went forward in the last full council. There was going to be a task group involved in that. It's a massive public health issue, and it really involves the local plan, about how the local plan impacts the design so that young people have the ability to use their bodies and have better public health. So I know that it again went to the climate emergency panel, and the chair there was reluctant to take it forward and didn't seem to understand the issue, from what I can gather. And I'm just wondering how it gets taken forward by this committee and this group.
Okay, you'll be pleased to know it's on the agenda for our meeting for next week of the chairs and vice chairs meeting. And from what I understood, we were not necessarily looking at a task group, but obviously we will. Definitely a report should be coming to this meeting, but I might be preempting that discussion that we're going to have next week.
The Council resolves to set up a play scrutiny task group to consider play provision, any gaps and future needs, and that was what was agreed in the motion.
Okay, I think there's a difference of view here, so we will take it back and we'll have that discussion, and then we will respond accordingly to this panel, okay? And to you specifically beforehand. Sorry, were there any other questions for the Cabinet member? In that case, then, we will move on. And the next item, in fact, I'm going to change the agenda, because I know that the officer, I think, Sarah, you need to go earlier. So if it's okay with you, would you like to just give us any... Sorry, Alison, would you like to give us any additional information on this report? And you will be duly supported by Sarah.
Okay, thank you, Chair. This is the first time that we've brought this report to this group, and that's because it became relevant after we took adult social care services back in-house in 2024. So this covers the first year of the contract being in-house. And the figures are counted differently, because in the past HCRG used to do the first section of the first part of a process, and the council got involved at the second stage. So this is very much a baseline because of that, because we cannot really compare with previous years in any way. So it's really for information, it's a baseline, and we will be bringing further reports in future years.
And just to confirm, as this is the baseline, we would then always have this, as a reference point in those future reports, so they wouldn't be sort of standalone without any sort of anything to compare with. Good. Sarah, did you want to add anything?
I don't have anything to add, but yes, to confirm that point, we will use this as a baseline, and there'll be comparisons going forward in coming years. In fact, I've just started the figures for this coming year, so it will be with you during the year to look at that.
And actually, would we expect it to be at this time next year, or would it be...
It'll be earlier.
Much earlier?
Yeah,
okay.
It will. I'm
Good.
working on it now.
Thank you very much.
Yeah.
Okay, so bearing in mind this is a report more for noting, but I am happy to take any comments or perhaps anything that people might think is of use in terms of that future report being written. Leslie and then Kevin.
Yes, thank you. I think we've said this before in this panel, but I think the important thing is that we took these services back in-house. So the CQC inspection was not on what we've done, it's what we've inherited. And there's been some good improvements from my reading of the report. So the assessment waiting list has been reduced from 201 to 81, which has got to be something quite remarkable. The OT waiting list has been reduced from 229 to 58. And again, I don't think we should lose sight of these massive changes. And case audits, 83% of people rated their experience as positive, so this is all good. And it's good to hear we're going to get future reports where hopefully we're going to see not just the intention, but that things have happened and they can't carry on with that. And I would say that the previous provider was HCRG, so we just need to keep thinking about this and how these services have been provided and will be provided in the private sector, and that we've clearly shown that we can do it better.
Sorry, Leslie, are you talking about the annual complaints report? So we'll park your questions for now. And did you have any questions you wanted to raise on the complaints report? I'll come back to you. Kevin.
Yeah, thank you, Chair. On page
Kevin, 9... can you move your papers off your microphone?
Yes, I'll try and juggle. Sorry, the question I've got is on a different page. Sorry about that. Yes, so the table at the top of page 95, where you've got number of new complaints received, upheld, partial upheld, percentage of complaints upheld by the local governments, the ombudsman. I understood the first two columns, the number of new complaints received, and then whether presumably they're upheld or not. I wasn't quite sure where those two numbers, or the two preceding numbers, fitted in with the percentage of complaints upheld, or does it mean whichever ones went onwards, then 75% would be upheld? And if there was a little numbers in there about what the, is it saying that for the first row, assessment and care planning, for example, 37 of new complaints were received and 11, presumably at the first stage, were upheld or partially upheld. How many of those then went of the 37 onwards, of which 75% were upheld? Do you see what I mean? I wasn't sure what number went on, and that didn't seem to sort of... Just that was a passing observation for next time. But can I my two questions really were, and again, I understand totally that it's a baseline report, if you like, but what do you take as the sort of concerns from this report, and what do you take from this report as the positives?
I can start with the positives first. Certainly in terms of complaint handling and responsiveness to complaints, which I think is key to the point that you were making, and I completely understand what you're saying, the first point about it not being clear with the numbers, but I think the point being made, if we don't resolve complaints at an early stage, that they do escalate to the Ombudsman, that creates us quite a lot of work, so, and they're significantly more likely to be upheld. So, judging by those numbers, that was the point of that. So, I think the positives from this is that we are, certainly the service is very good on response times now with complaint responses, which we know anecdotally, it isn't proved, but if you respond to a complaint promptly and within time, it is less likely to escalate through further stages. So I think that's very positive. I suppose in terms of concerns, we are seeing increasing numbers generally, and that's continuing. I don't know if it's a concern, but we need to keep on top of that. Good response rate, good comprehensive responses, which we, I think, since we've been dealing with them within the council, we've been doing good responses, full responses. But we've got to keep that going, and we've got to learn from what we hear from those complaints, you know, as they come through. And I'm working with Suzanne's service quite a lot more now with looking at the learning from the complaints. So I think, I think what I'm saying is a continuous learning journey, really, with these complaints.
Did you want to talk about the negative side?
Well, yes, I suppose I'm just saying, I think in terms of the negative side, it is the numbers going up, really, but that partly that is to do with the difference in the way that we account for complaints than HCRG did. We are far more, we follow the regulations very closely, and we will record a complaint as soon as it comes in, as opposed to dealing with it as a concern, which then wouldn't have been a recorded number. So I think that the sort of negatives are we are dealing with a lot more complaints than we previously were, but that the way that we're dealing with them, or Suzanne's service are dealing with them, is I think, very good. And often, and I did include some information about the Ombudsman, and again, in this report, we were still dealing with complaints that had actually been against HCRG and not the council, but they've worked their way through the process now. But many times our complaints will go to the Ombudsman, but they don't take them forward as an investigation because they're satisfied with the quality of the response at the first stage. So,
thank you, Sarah. Okay. Kevin, you can come back if you like.
Yeah, just a quick follow-up. I was just thinking, that were there any complaints in particular areas that are generated just because of external circumstances to the service? For example, I might complain going into the local supermarket the prices have gone up again this week, or at the petrol station. Are there complaints that are out of your hands at the moment, and can you see any ways, you know, just to highlight those that we might look at for next time, or at least explain possibly a little more?
So I think the area that probably doesn't show up quite so much in this report, but will be in the report that I'm doing, is we do inevitably have a lot of complaints that relate to finances, charging for services, and this year there has been a change in the benefits system. I don't understand it. I think it's quite technical, but it has changed people's assessed weekly charge, and we've seen complaints on the back of that. Now, that is out of our hands because it is a changeover for DWP rather than the council. But when Care Finance come to reassess people, then they find that their assessed weekly charge has changed, and we have seen some complaints on the back of that. I think particularly in the younger groups of adults rather than sort of older residential care figures. So I think that's something that will emerge through this year, really. We've noticed that particularly in this last quarter of this year, so the third quarter, as people's weekly charges are reassessed. And I'm anticipating that will be an area that comes through.
Thank you. Leslie? Yes, apologies, Chair, for picking up the wrong report. I've got mine in a different order and I didn't quite hear what you said. So on the Ombudsman, around equalities and accessibility, why is the disability data missing, which it says is admitted for 87% of complainants, and ethnicity data is missing for 61%? So what is being done to make sure that this doesn't mitigate a further risk in the future? And also on learning and improvement, how is the complaints team ensuring that learning is shared across commission providers and not just the in-house services?
So in terms of where the data's missing, until this year, we haven't had a means of collecting that at source, if you like, at the point that somebody makes a complaint. As of the 1st of April this year, we now have a new the database where the public can log their complaints, which people are using increasingly, now asks those questions around ethnicity and disability. So it won't come through so much in this current year, but certainly going forward we will have that data, and that has been really waiting for that. We've had the whole of the database that sits behind the website and people's ability to put online. We've had all of that reviewed this year, ready for the 1st of April, because there's some work we've been doing with the Ombudsman around complaint handling. So that should show. I've known for a while that it's a failing in our figures, but we should be showing those. I'm sorry, I can't remember what the second question was.
The other question was around the learning and improvement. So how will the complaints team ensure that learning shared across the Commission services and not just on the in-house services?
So at the moment I meet with Natalia, who is the head of commissioning. I met with her team a couple of weeks ago, and we had a conversation about complaint handling and what's coming through from the Commission services and how we can share that both ways. So I think over the last year our sort of relationship with the Commission has improved a lot. And I have talked to Natalia about potentially putting a separate, I'm going to have to look at how it works, but a separate section in the annual report to talk about complaints about Commission services. But it is, you know, it's about developing that relationship really, so that we can get feedback through the commissioners, and that they can pass it back out the other way. But it is noted as an area we need to develop.
Thank you. Do I have any more questions from the panel? I'm sorry, Sarah, I forgot to actually specify when we could expect the next annual report.
I am writing it at the moment, but I usually share it with Suzanne's senior management team. So I think in the past it's sometime around September, if there's a meeting around there.
There will be a meeting, but whether or not it's a children's meeting or an adults meeting, I think we'll just
so the nearest to that kind of time.
Okay. We'll make sure that that's within our agenda setting. So thank you, Sarah, and we look forward to, well, hearing the next iteration. Thank you, and thank you for taking on board all the comments that have been made today. Okay, so the next item is, so I've got myself confused now. I think we're now on the ICB update. So thank you, Lucy, for all the comments you made so far on various other matters. Is there anything else you wanted to add in addition to your report, or do you want us to move straight into questions?
Mindful of time, Chair, there are a couple of things, if I may, just to add. So on the dental update, just to provide the panel with assurance that if funding is handed back, the funding is recycled into procurement and commissioning, and all current funding is fully committed. On the blood pressure roadshow, just to feedback, as per my report to Councillor Harding's question last time, we now have a partnership with 3SG, our VCSFE partners, and we're exploring further blood pressure roadshows in more rural areas, and happy to bring any update on the timings of that to future meetings. On neighbourhood plans, I just wanted to update that a multi-agency Baines locality workshop was held last week to work through options for neighbourhood footprints. As a reminder to the panel, the Health and Wellbeing Board will sign off those footprints, but again we are happy to bring an update as we work through the options. Working with colleagues in public health, we've been discussing termination of pregnancy and access to contraception. Just an offer, if it would be helpful to the panel, to bring an update on the sexual health needs assessment to a future meeting. There is an update as requested on NHS 112 and the contingency arrangements. If there are any questions, AWP are really happy to have further feedback on those changes. I can confirm the first patient into the new learning disability unit in Bristol that has been delayed due to flooding will now be the 5th of October 2026. We have been working again with Public Health and with Darryl just around meningitis readiness. Just to update that as an ICB we've been heavily involved in the recent response in Dorset over the weekend, and we will be taking and sharing learning from that response along with learning in Kent, just around conversations around readiness. And just finally, if I may, Chair, just to note the new identity for community services. Panel members are probably aware of the new single point of access that's been mentioned previously in the meeting. Just to say, it's just...
Sorry, Lucy, you might want to just pause for a moment. And now, could you go back to the name, because I completely missed that.
Sorry, yeah. So the new identity for community services is BSW Community Health. The new single point of access has been launched, as has been alluded to during earlier discussions. We are very keen to hear any feedback in relation to that new single point of access. Thank you, Chair.
Thank you, Lucy. Sorry, I know that BSW is kind of bandied about quite a lot as a geographical area. In this instance, around community health, does that also now include Dorset?
No, just a reminder, Chair, the community health is only for the HCRG contract that covers Baines, Swindon and Wiltshire.
Thank you. Perhaps we ought to have a handy glossary of all these acronyms to hand.
I apologise for all the acronyms in the NHS.
Which in itself is an acronym. Okay, thank you. And I'm personally quite pleased to hear that we're already looking at our readiness for any potential meningitis outbreaks. I assume that also includes making sure that we've got sufficient stocks of the vaccinations and the antibiotics, etc., which I suspect is a Paul Scott kind of question.
It's a joint question as we work in collaboration. So one of the things we're looking at is just to ensure that the contact details we have, should we need to stand anything up in the Baines locality, are still in place with all the changes we've had, particularly within the ICB. So we're just making sure those contact details are all known. And as I described earlier, Chair, we're working through some of the challenges in other areas around availability of drugs, etc., and taking the learning from that, and we'll be discussing that collaboratively with our colleagues in public health.
Paul, did you want to add anything? You just say yes.
I'm basically saying I don't have anything to add. I think Lucy summarised it very well.
Thank you. Any questions from the panel? Oh, I'm going to take David first, and then Joanna, and then Kevin, because you all put your hands up at exactly the same moment.
Thank you, Chair. It's a question for Paul, really, on meningitis prevention at work, etc. Are we doing anything around messaging around vape sharing? Because it's, I gather, rather common.
Yeah, well, good question. I don't think, there's two, I think it's unclear whether vape sharing and how vape sharing does have an impact. I think, if anything, there's thinking that the act of vaping, like smoking, damages the lining around the throat and the nose and so on, and it's that damage that makes you more susceptible to existing strains that might be around. So it might not be just sharing a glass, sharing a vape. So there's a little bit of clarity still to be found about that. I think it's a difficult one, but I think people will have heard from headlines and things nationally, won't they? So there's something around that. It's still a very rare occurrence, so I think there's not clear comms about different kinds of arrangements you'd want to put in place and to alarm people. But yeah, I would suggest people just don't vape, especially young people. It's probably the safest thing to do.
Joanna.
Sorry, can I just pick up that people are vaping and they are sharing, so how do you communicate that that's not a good thing?
Well, I think it's a good question, but I mean, I think I say it might sound a slightly difficult. I think tobacco will obviously be causing enormous amounts of harm across the country, so I tend to say that as a serious point as well. I don't think it's quite clear what our messaging is yet, but the universities are doing lots around preparedness as well. They have good pathways for meningitis. Outbreaks are very rare, but single cases are not uncommon. I can take that away and look at it. I can see if there's learning in other areas, but yeah, I think the evidence isn't quite clear. But
All right, thank you. Thank you for your response, and Lucy. So one of my questions was, following the national press coverage, does BCSW hold data on how much funding has been returned to the NHS by dental services? And the answer was financial updates on the level of underspend are reported through PCEG, and BSWICB is cited on these figures. But can I have those figures? Are those figures available?
So, thank you, Councillor Wright, and apologies again for the acronyms. That's our Primary Care Executive Oversight Group. In terms of the figures, I have asked for them, the exact figures. I haven't had them yet. What I have had is the statement I read at the beginning, which is around the assurance that if there is any hand back, that is automatically recycled into further procurement and commissioning for dental services. I will take that question back again to the dental team to say, can we have the exact figures, please?
I want the figures. Thank you. Following up on two other things, on the sexual health issue, please, yes, can we have a further report on that? You mentioned, again, what was I wrote it down?
Thanks. I've been working with Amy and the public health team, and we are very happy to bring back a further report.
I think that's really important. Thank you. And then there's been a lot in the press recently about sort of misogyny in public health towards women, and various issues, but I have received an email from a local resident concerned about iron deficiency and how she has repeatedly gone to her local doctor to get support and has suffered severe exhaustion and dizziness, breathlessness, hair loss, brittle nails, compromised immune system, poor sickness at work, etc. And women are, lots of women are reporting this. They're then given supplements of iron supplements, and actually they aren't working, and what they actually need is IV, but they won't be sent to, there doesn't seem to be enough offer of that, and their local doctors won't give them that support. So they aren't being referred, and they continue to suffer all of those problems. There seems to have been a conversation of a whole load of people in Bath and North East Somerset, of women complaining about how they have all had this issue. And I just wonder, asking you the question essentially is, what kind of data can we find out about IV use that's given to women, how many women are, and how many women are going to doctors reporting this issue, and how far it's being escalated. And also, when they do take a blood sample, you get a level, and we must know from the data that's collected from blood how many women have iron deficiency.
Thank you, Councillor Wright. Noting the questions in there. So one of the things that's recently been launched is the National Women's Health Strategy that we're just working through. What does that mean? And one of the actions I will take is to check to see if this subject is mentioned within that strategy, particularly around a number of things that impact on women. In terms of your particular question about IV therapy and data, I will need to take that back and check what data we hold. I suspect we won't hold an awful lot of data because of the way we commission. We don't always get individual reporting, but I can certainly go back to our acute hospital providers and primary care to say, do they hold any data, and bring that back.
Thank you, Lucy. I think that would be very helpful. And I would particularly be interested in that, the National Women's Health Strategy, I think you said. With my membership of the Women's Commission for WECA's hat on. So thank you.
I'm very happy to bring a further update just to break down that women's health strategy a bit more to a future panel.
Yeah, just picking that up again. I mean, as somebody told me recently how their daughter in her 50s died of cancer. She just thought she had back problems and it was related to the menopause, and nobody picked it up, and then she's dead. So I think there's a whole issue around here about women's health and how we don't treat it seriously and the issues around it. We certainly know that lots of women who are young women with periods aren't treated seriously when they complain about endometriosis. I can't say that word. But I do think that we as a panel should really be asking for more on this and taking it further and having a report, Chair.
Absolutely. No, I support that. And I think actually there is an additional forum that we could be looking at as well, which I sort of suggested too. I don't think I've got anybody else who wanted to... Oh, Kevin, I'm sorry, and Leslie, and Eleanor. It sounds like I've got loads of people who want to speak. Okay, Kevin and then Leslie.
Thank you, Chair. Yes, a couple of questions, bless you. First one is, I'm still hearing lots of things about the ICB clustering and the intention or the ongoing move towards the Dorset area that way, and other things saying, no, the council wants to go the other way with South Gloss and various other places. And my question really is on this one, and it's not the only question I've got, is does it matter? And if so, what are the key things that matter that we should be thinking about here? And are we going to get a say in this, or is it being decided elsewhere?
Thank you for your question. So we're having regular conversations with the ICB and local authority just to understand the options, and we will continue to work together. In terms of your question about does it matter, I think that's the thing we're working through. What could it impact on? But just to confirm, at this point in time, no decisions have been made, and we continue to discuss all of the options collaboratively.
And perhaps I can add to that one if I may. So where it matters is about the future footprint of local public services. So we are a committed member of the ICB, as it currently is as a cluster, but we're also a member of WECA. So the WECA footprint is different to the ICB footprint. The role of mayors is changing and arguably is moving more into the space of health and social care. So that's partly why we're having the ongoing dialogue with our colleagues in the ICB and other public services at the minute. So I'm thinking, how do we get the very best possible service for citizens of Baines, but also how do we position ourselves so that we are connected to the authority of mayors going forward and ICB commissioning arrangements. So it's a live debate, but as Lucy said, no decision has been made at this point.
Bearing in mind, I suppose, that it matters in terms of local health, then will this panel get a view on these are the options and a view from us on this particular service?
So I would anticipate that this committee would have a view and a time to have express an opinion and get involved in that. But at the minute, we're having a conversation which is largely hypothetical because there is actually no mechanism for changing ICBs. So we don't know whether it's in a local decision that could be made with key partners, whether that would be a Secretary of State decision or others. But yes, there's a process that we would need to go through which involves Cabinet and full council and scrutiny at some point. But at this stage, I just want to stress it's a hypothetical options type conversation that's going on.
And just a final follow-up on that particular point. So when will it be will we pass any points of no return in terms of, obviously there is a direction into travel in one way, and so just by sheer direction of travel, certain things will happen which will then have to be reversed if that direction of travel is not going to be the final end point of the journey.
So I'm looking to Lucy as well. I think I'm clear that Councillor Vaughan also wants to come in. But so, to my knowledge, no, there isn't a point at the minute in the timeline because, again, there's no mechanism for making the decision. The ICB cluster that we're engaged with as an active partner are aware that this is something we are thinking about, as is another local authority that may well be looking in a different direction in terms of their own mayoral authority. So the ICB are aware and are making plans that are in the hope that we all stay together as we currently are, but also with the possibility that maybe we won't.
And this isn't the first time you've heard this. So, Alison.
Yeah, I just wanted to add, one of the things that I think is helpful in the fact that this is very fluid and it is still being debated is that the ICB cluster has put a big emphasis on place and teams around place. And I think that enables us to keep our options open and is protective, whatever the final outcome is. So I think that's a really helpful position that they've taken.
Thank you, Alison. Kevin, did you have other questions?
I did, bless you. Sorry, that was just a taster. Sorry. There's only a couple, bless you. The first one was there was an operational review of the out-of-hours emergency department you mentioned. Just wondered why there was an operational review and what you hope to achieve with any new practice that's been put in following the review. You know, why the review, why the change, what's gone for the better?
Can I just confirm you're talking in relation to the 111 mental health item?
I was looking at the heading that said out-of-hours emergency review, or OO. I presume OOH was out of hours.
Out of hours,
It took me a while to work it out.
So my understanding that is linked to the mental health item. The reason the review was looked at is because there were some business continuity issues with the current offer, which is why they needed to review and why they've been putting mitigations to manage as part of the conversation. So the review was driven by a business continuity issue.
Okay, fine, great. And the last one was that you mentioned at the end, towards the end of the report, about the new community health model. And have we heard? No, I haven't heard anything or seen anything. And should I? And who's it for? Is it for everybody or just for certain people who might want this particular service and don't know anything about it?
So one of the items was the new name. There is a new single point of access, and HCRG are disseminating to make sure everyone is aware of it. So it does affect all professionals, but also all members of the public, because it's a new way of accessing the service. So all current and previous ways of accessing community services are still in force while this change happens. But I'm very happy to take an action back. So if you've not heard of it, they obviously haven't reached everybody they need to. So I will take an action back about how they are communicating in particular with members of the public around the new single point of access. Thank you.
Thank you, and thank you, Kevin, for all your questions. Leslie and then Eleanor.
Yes, thank you for the report, Lucy, and your previous contributions. I wanted to pick up on the Kingfisher unit. Do you have any idea of the new timeline for this opening and what's in place for patients who would have used it at the moment but can't? This was the flood, if you remember. On the termination of pregnancy, the reasons that women go for terminations are complex and many, yet the highest number of people we've got are in the 25 to 36-year-old age group. So what is being done to ensure that more information is going out and that more health interventions are being planned? And then I'd like to come back on the single point of access as well. Thank you.
Okay, I think you did already mention the time that that unit would be open, didn't you?
So, as per my opening statement, it's the 5th of October for the first new patient. So that's the timeline. In terms of your question about support whilst there's been a delay due to the flooding, all the staff were recruited and ready to go. So AWP, who are our provider of that new unit, are using the staff to bolster the outreach team. So that is provision where we are fortunate to have a base for that team within Bain, Swindon and Wiltshire. So that team are working in the community with other community teams, but also most importantly with people and families to provide support whilst there's been a delay in the unit opening. So that is all in hand, and we're monitoring that, and we can see the increase in activity and the positive impact that's being made. In terms of your question around termination of pregnancies and contraception for that age range, we did debate that, if you remember, Chair, at a previous meeting. And as I said earlier, we're working with Public Health, and we'll bring a paper back around the work being done to ensure all women are aware of options around contraception and termination of pregnancy to a future panel meeting.
Okay, can I just pick up on the flooding question before Leslie comes back, which is, I assume that this was a one-off event and it's not expected to be, there to be more flooding incidents.
It's a very one-off single mechanical failure. It wasn't a general flooding incident. It was due to a mechanical fault within the lift shaft, so we are not expecting any further incidents.
Leslie.
Yes, thank you. I wanted to pick up on the single point of access, and thank you for your statement already. This is quite new, and you've asked for feedback, so I'm going to give you some of what I'm hearing already. I'm hearing from residents that they're really struggling to get through on this new phone system. So it'd be really good if we can have a report fairly soon on how well that's working, you know, what the figures are for calls and what the unanswered call rate is as well. And alongside of that, I heard from a community nurse who had said to me, I've come back from leave and expected to have a number of cases to deal with regards to hospital at home. And that's important, obviously, because the hospital at home is about ensuring that patients can come out of the hospital so, you know, we can use the beds rather than stay there. And she said there was nothing there at all. So she tried to get through on the system to find out what was happening, and she struggled to get through and actually ended up with a consultant ringing her because she's worked there for a long time and they've got her number. And the consultant said, would you deal with this case because I can't get through on the system. So could we have a look at that and see what's happening? I'm concerned if it's starting to limp along already when it's only just started. And she said it's not just hospital at home either. It's people who've got blocked catheters and they're not getting through, so they're obviously going to be at least in discomfort, if nothing else, which I can't imagine at all what that's like. But and she ended up by saying to me, I just feel so embarrassed for the service because it's not happening. So it'd be really good to get a report on that, I think, sooner rather than later, and hopefully you'll iron out some of the wrinkles in it. Thank you.
Thank you. So we are collecting data on the number of calls being received and those being unanswered as part of our scrutiny of the start of the new service. So I'm very happy to share an interim report on those numbers. But just to note, we are aware and we've heard feedback around public and professional concern about being able to get through to the service, and that's why we've asked for that report. So very happy to share that before the next meeting, so we can ask any more questions of HCRG, and the feedback is much appreciated. Thank you.
Thank you. I don't know if it will be too broad a scope, Lucy, but I think we will have all heard various concerns raised around different services where it's been difficult to get through. So if it's possible to expand that so that it encompasses perhaps all the services where people, maybe all the health services might be too broad.
I think that's a bit broad, Chair, because there's so many commissioned services. May I suggest we start with the SPA as it's new, and that does bring a lot of those entry points into the NHS together. And then if panel members have any other feedback about any particular services, I'm very happy to take that question back.
Okay. Thank you, Lucy. Eleanor.
Whenever any service like this is introduced, I get worried about the number of times my residents get referred to websites, internet connect information and so on. And I think what we've just heard is really quite concerning, and it's not known generally that officers in the Hollies and Manvers Street and so on will always help residents who can't access the internet to fill in responses and requests and so on. However, it's really, there seems to be a sort of insidious kind of rationing going on, that you can't get routine tests for types of cancer if you're over 75, but it seems that unless you're over 75, you can't get a COVID jab. And I was wondering how it had been decided what categories were eligible for the COVID outbreak, well, COVID vaccination that's to deal with the current outbreak and boost your general COVID response. The people, the residents I know and the relatives I know who've had this latest form of COVID have been really ill. And so, you know, you want to urge people to get a vaccination if they possibly can, but it seems this is very difficult. Can you explain how we get these criteria? Who can have a vaccination and who can't? And what I'm particularly interested in is whether the medical professionals at the RUH are having any sort of take-up, and what, in the general COVID outbreaks that we've had, partners of medical professionals have been eligible. And I wondered if that shouldn't perhaps be the case now.
Thank you. So if I may take each of those questions. In terms of internet access and digital enablement, just to give an example linked to the SPA that we've been discussing this morning, we've been very clear that there needs to be an offer, because not everyone can access the internet and not everyone is able to use the digital front door. So there is also an offer linked to the phone line, acknowledging comments made about ability to get through. And as we develop together our neighbourhood health offer, that's going to be really important about not everything being through a digital front door. There needs to be a corresponding parallel offer for people who are not so digitally enabled. In terms of routine tests for cancer and COVID vaccinations, that's all based on a clinical evidence base in terms of risk. So, for example, the COVID vaccine is available for people who are over 75. Those are in care homes, etc., where their risk is deemed to be higher, and that's all based on a clinical evidence base. Acute hospital doctors wouldn't always get involved in those decisions. They're made with public health experts and other experts who have the information around understanding that type of clinical risk. So those are set nationally, and if there are individuals who fall outside of that but have other risk, those can always be addressed via a GP, but that's why we have the nationally set standards for who is eligible for cancer screening and who is eligible for vaccinations.
Can you just remind us of the body that sets that criteria? No, we've done nothing wrong.
I believe, Chair, that's the UK Health Standards Agency, UKHSA, who are the overarching public health body that look at clinical risk and evidence base.
Thank you. And thank you, Paul, for your intervention there. Right, I don't believe I've got any further questions, apart from one from me, which was about, what was it about? Vapes and universities. Oh, we spoke about working with our universities, which I assume also will include our probably our colleges and also Norlands as well. Obviously, we have a lot of young people that go elsewhere for their university education. So is there sort of like a national strategy where all universities are involved in terms of ensuring that you know, any potential meningitis outbreak is you know, that we are collectively, all universities are prepared for?
Thank you, Chair. I can try and answer a bit, although I don't think there is a clear answer. I don't think there's a national strategy or approach, but there has been ongoing work for a long time with our partner agencies, because we do see at that point where lots of young people come together, we see incidences of not only things like meningitis, where for this strain meningitis B, there hasn't been a vaccine in that older teenage age group. All children under 10 now should have had meningitis B vaccine because it's been in place for babies to have that vaccination since 2015. So all our primary school children by now should have been vaccinated against meningitis B, or have at least had the offer if they wish to do it, and most children will have done. So universities are good about promoting things like MMR vaccines, because we do see measles outbreaks sometimes, and meningitis B isn't available as a catch-up, and you will have heard information in the news about that and debates about it. So we may see that change, but at the moment, such as in Dorset, which has just been stood up to have vaccination offered to those school children in secondary school who are in the affected school areas to have vaccination, but that's something that will take a few weeks and give them some protection. So that I'm not aware of a national strategy, but there is obviously a lot of joint working going on at the moment between universities, between public health teams, the UK Health Security Agency, as Lucy just said, to give guidance about how people approach things. So I mean, I can share some information afterwards about what our universities, so Bath Spa, University of Bath, Moreland College, Bath College, I'm sure they're all trying to channel national advice to young people. And perhaps just to correct my answer earlier, which wasn't necessarily that helpful, it is naturally a helpful thing not to share vapes. So, I mean, if young people are thinking about that, a sensible step is to not share vapes, especially in those more close and intimate settings like a nightclub or something like that. But yeah, there isn't a national strategy at this point. And just to remind, it is a rare thing, but it's obviously a very quick and rapid and sometimes devastating disease for people. So it's finding that balance within that context.
Yeah, I think that's interesting because it seems to me, knowing that our young people are very mobile, that feels like a bit of a possibly missed opportunity. Or certainly something is being missed in order to just treating young people, as though they only, are in one place and they don't go anywhere else from that university or that place of higher education. It just feels a little naive.
Yeah, meningitis can be caused by virus or bacteria, and this is the bacterial type that's the particularly serious one generally, and this is the one we're talking about. And it's not easy to transmit, so when a case of meningococcal disease happens, they will be doing contact tracing, you'll have heard about it. The close contacts will be offered antibiotics to clear any bacteria in those people in that close circle. They may be completely asymptomatic, not affected by any ill health, but they may be carrying it in their nose or throat. So the antibiotics, the aim of that is to clear it within that small family or friend group. Just someone sitting here today, for example, is unlikely to cause any problem if they were carrying it. I'm just saying, there's an example. However, someone spending an entire day in a very close setting with someone, sleeping overnight and sharing the same crockery and utensils and things, that would be a close contact. So just being in contact with people is not considered to be a high-risk source of exposure, which is why we don't generally see outbreaks like you would with flu or COVID or those kind of things. It's still generally, thankfully, a very rare condition to see.
Thank you. Right. Okay, I'm going to move on to the next item, which is, I think this is now the Adult Social Care Improvement Plan progress update. Alison, if you'd like to give us anything extra in terms of the report that we have before us. And I know that Leslie will definitely have a question or two.
Okay, yeah, this is our most recent update on our improvement plan following our CQC inspection last year. It's very comprehensive. It covers a huge number of areas. We are making good progress, but the progress is more in some areas than in others. And I think rather than go into it in detail, I'll just be happy to take questions, really.
Thank you. Leslie, did you want to just sort of précis your question that you asked before?
I'll try and remember what I said. But I think the first thing is that there has been some major improvements, and we need to congratulate the staff for managing that, and that also that we inherited a lot of these issues. It wasn't anything that was being not done by Baines in the past. And I think for me the question's really around, there's a lot of strong intent within the report, but there needs to be a little bit more evenness around how this is going to be implemented to make sure that that progress continues, and we don't slip back to where it was before. Thank you.
You can come in. Yes.
Thank you for that, Councillor Mansell. What I would say is that it's not just an intent. You know, the evidence is that our waiting times are down, our staff practice is much better, we're improving all the time our safeguarding policies. We've got one independent review already done around cope reduction, which is working together, and we're in the process of the safeguarding peer review, which we commissioned, and we're in the process of doing that right now. So the evidence is there around all the work we're doing. One very good example of that is our OT assessment centre. So I just thought it was important just to say that, and the evidence coming back from PCH, which is the Partners in Care and Health, who are supporting us on this, and are sort of the engagement workers of the Department of Health and Social Care, have told us that we are on track to deliver. Unfortunately, I do expect a CQC inspection in the next 6 months, because they've done a whole 153 councils. They haven't published them all yet due to elections, but they will publish the last, I think it's 15, after the May elections, and then they've started a new process, and we're likely to be top of their agenda on the new process because it's 2 years ago, and also because we were RI at that time. So I would expect them in the next 6 months to be coming to the council and reassessing. I would like to think that we're ready. We've got some very good evidence for them, and we will share that all of the independent reviews we've had as well with them. We've just completed our self-assessment, which we'll have available publicly in the next couple of weeks. So we're in a good position, a strong position with evidence, and we are ready for CQC to come and see us.
Okay. Thank you. Any other questions? Michael and then Kevin.
I was just interested in knowing how the work around direct payments had been kind of progressing, because I know it's an area that's been looked at with a lot of urgency in terms of encouraging more use of direct payments.
Yes, thank you for that question. We have appointed about 6 months ago a person, direct payment manager, who also comes from that background, and that's noted around that. So she's helping us develop a direct payment offer. We've seen an increase in the numbers of people using direct payments as well. I would say that's one of the areas that Councillor Bourne just talked about. We've got really strong areas, and that's taking that bit longer because many older people in particular don't want to take up direct payments. They're really struggling with that. So it's one of the areas that we're out talking to people, showing support, developing the PA market, but it does take longer than just the time we've had, but we're increasing our numbers each day.
Thank you. So next is Kevin and then Eleanor.
Thank you, Chair. Well done for all the hard work. It's always a difficult journey when you have these things to do. Just really listening to Councillor Bourne, there was a few things possibly you'd like to be further on than not. So what are the areas at the moment that you're sort of focusing on or maybe not quite so happy with?
We're just in the process of setting our priorities for this year, which we will have available in May. It's the personalisation agenda that we've just talked about, direct payments, greater work and focus on that. I'd like to see the waiting times go down more into single figures, and we're putting extra resources into that. Our digital offer is good, and we're working with, we've agreed 60 people to work with them about their experience of coming into adult social care, how that felt. So it's new people just about to come in, families or individuals, or people who've already experienced it. And we know what was good and bad about coming into adult social care and how we could improve. So they'll be our priorities for this year, the 3 priorities. The areas that I probably feel really delighted about is the quality of the practice has improved, and also the OT Assessment Centre. I think that's really made a difference to people's lives. And thirdly, it would be safeguarding. Our whole process, planning around safeguarding and making safeguarding personal has been very good.
Eleanor.
Well, thank you very much for the report. The problem with being a ward councillor is that people reach for the phone and ring you up when, first of all, they feel they've exhausted all the possible avenues to get the changes in adult social care that they want. They think you can wave a magic wand, and the trouble is trying to signpost them in the right way to the right level of help that they need. And I was, wondering what could be done with people who claim to have waited a very long time for either a medical review or a needs review, social needs review of the person that they're caring for. That's the first question. And the second question is, there's a group of mothers I'm in contact with who are now approaching their 70s and are very concerned about who is going to look after the person they're responsible for when they're no more. And is there going to be any extra provision for residential care, or how will things work?
Thank you, Eleanor.
Thank you for the questions. First of all, to say the advice and information and our prevention offer, often people will come to us and feel that they need adult social care. They may not fit the criteria, and that's why the prevention offer, and in particular our voluntary sector offer, is fantastic. We've invested millions of pounds into the voluntary sector and what they can offer to people who need support. So Age UK, some of the work that 3SG is doing, the work we're developing on the compact, our arrangement with the voluntary sector, so that there's a range of services available to them before they come into adult social care. And I think that's really important, and we continue to develop that. There's always more to do in advice and information, but that's why I was talking about those 60 people and their experiences, because many people will not want to use the digital. They want to pick up the phone, or they'll want a letter, that they don't use the internet. Now, the majority of people over 70 are digitally aware, but there are quite a lot of people that we support are over 87 and onwards. The profile of the older people has changed, so we're also talking with people about what else do we need to do, which is paper-based, phone calls, what else would work for those family members around advice, information and prevention. The issue around, and I think you're talking about learning disabilities in particular, Councillor Jackson, so it's the older parent who is looking after a 40, 50-year-old their child, and they're concerned about what will happen to them. Now, we track those people. We have a list of all the people that we know that their parents are getting older, and what we need to do to support them. We're working with many of those families, but there is, and I can think about 4 people I've been talking to recently, they want to keep that person at home with them, but they want to have a plan for when they go. And I'm often saying to them, The plan needs to be now. Share the plan now, whether it's shared lives or it's with support from social workers. Put it in place now. Don't wait till there's a crisis. But many people struggle with that because they've done so well with, you know, looking after their son or daughter that they really don't want to hand the person over as they see it. But we do track them, as I say, and try and encourage them to join sharing arrangement with us. So they stay at home sometimes, they're in day services sometimes, they're in shared lives. You know, what feels right for that individual.
Thank you. Darryl, I know you wanted to come in. I think it was in response to an earlier question. Okay, so any more questions on this item? In that case, then I will close that item. And we are... Sorry, Darryl now wants to speak. Sorry, I thought you said you didn't want to speak.
It was not in response to a question, it was just to build on comments that were made.
I'm so sorry.
No problem.
I misunderstood.
So I just want to say that both Councillor Orton and I had an opportunity to visit the OT Centre recently, and it was an absolute pleasure, and it's a really valuable and excellent resource, and I think to be commended. And I've had the privilege in recent months of chairing the Adults Improvement Board, and I just want to say we've heard from Suzanne in a typically modest way about the improvements that have been made, some of the challenges and also the priorities for next year. I just want to praise Suzanne really for the leadership she's played in this space. The improvements since the CQ inspection have been formidable, and she and her team work tirelessly and are really passionately dedicated to outcomes for service users. So I just wanted to say that really. It's been an absolute privilege to chair that improvement board.
Thank you, and thank you for that recognition. I think Suzanne is quietly pleased. Okay, right. So I'm now going to close that item, and I'm fairly sure I've covered nearly everything apart from the panel's work plan, whereas we've got a number of items in that, very much not least the work that Lucy is going to do to ensure that we have some responses to the statements that were made. Also, we need to bring in the hospital trust as well to respond to the parts that didn't reflect well on them. And we have a number of items that I think you've picked up that you will bring to our attention in your next report, which include blood pressure, sexual health, and the AWP's work. I'm sure there were other things as well, which others I'm sure will refer to. Is there anything else anybody else wants to raise now as something they would like to see in a future meeting? Eleanor and then Leslie.
I'm not quite sure how to frame this, but it does seem to me, and we've heard the difficulty of medical access to hospital clinics and treatment and so on, but there's a very severe problem of accessing the Sulis Hospital in Peasdown St John, because the bus service has just been rerouted. That's the 522. You've got to be strong enough to walk from along Braesdown Road and through the estate and then across the busy bypass, and then you're at the hospital. But there's now a community bus from the centre of Bath to the hospital, and the question you have to ask is, how are people who live on the other side, the Redstock side, expected to access that hospital, which does run some really important clinics which relieve the pressure on the RUH. So, and I've got a number of questions about the bus service to the RUH. So, getting yourself through the door is what I would call a report that I'd like to see rather urgently. There isn't even the information about the bus service on the appointments letters that go out from the RUH. So you're just told you can park in area P1 and P2, and that's it. Nothing that there even exists any bus service.
Lucy.
Thank you. I think you raised some important points. I'm really happy to link in with colleagues and bring an update in relation to bus access. It might also be helpful to include in that update a reminder about those people who are eligible for NHS transport for appointments as well, because that offer still stands nationally. So I'll pull something together for a future panel discussion.
And perhaps what publicity you already use to promote such services too.
I should have mentioned, the more people who can respond to the current WECA consultation on transport, the better.
Thank you, Eleanor. Leslie.
Thank you, Chair. On page 115, the last item on the work plan is the community services transformation, and it's got Laura's name there, so that obviously needs to be changed. I think we need to be a little bit more specific about some of the things that we need. I think it would be good to have something in around home care, how many people are waiting for packages, the impact on hospital discharge, etc. And the other thing was, Kevin raised earlier on around the third sector and the impact of the budget. And it would be good to have a report sometime in the future around how well co-production's working and impact that the budget is making on the third sector contracts. Yeah, I think it would be good to have those two things there as well.
I would agree. Okay, and I'm sure we will have public speakers on that at that meeting too. I wanted to add one more thing. Leslie, can you turn your microphone off? That wasn't the item I wanted to say. I wondered if we could have something around our neurodiversity strategy, or if there is one, and how that's being implemented, how that's shared with our partners, and any updates that might be useful to proceed with. I'm thinking particularly around, I think we will all be aware, because it was on the news a month or so ago, about the experiences of the main person whose story was being written about, I swear, and it just made me think, I don't know what we have in place to ensure that those needs might be met, and it would just be useful, I think, as a panel to hear more. Okay, thank you. I'm not giving you a specific time frame just at this moment, though, for that. Anything else anybody wants to add to the panel's work? In that case, then, you'll be pleased to know that I'm going to declare this meeting as being over. I'm going to have to pause you there, Leslie, and then thank you very much for everybody for your attendance, and my apologies again for the technical problems we had at the beginning, and I'm sure they won't happen in quite that same way at our next meeting. But thank you.